Morning, everybody. Um, Welcome to today's webinar. My name is Judy Reven. I'm the interim director here at JFK Partners on the University of Colorado Anschutz campus. And today's topic, as you know, is autism assessment in adulthood, best practices and neurodiversity-affirming approaches. So as you go through today's webinar, feel free to type in questions or comments in the chat box at any point. Captioning can be accessed using the Zoom functions at the bottom of your screen. We ask that you please keep your microphone muted so we don't hear any background noise. And we are recording today's event and we'll archive it on the JFK Partners website along with all the other webinars that are in this series. We'll also post a handout for today, which you're welcome to print or save for future reference. Following the webinar, you will receive a link requesting an evaluation. Please fill it out. It really does help us inform not just this presentation, but future presentations. And you can also request a certificate of attendance in the evaluation. You are in for a treat with today's three speakers. They are Doctors Audrey Blakely-Smith, Kaylin Russell, and Ellen Wilkinson. And I'm just going to do a super brief bio about each of them because I know you're really eager to get into the topic here. But just so you know who you're going to be hearing from, Dr. Audrey Blakely-Smith is an associate professor in the Department of Psychiatry and Pediatrics here on our campus. She's the training director of the APA-approved internship within the Department of Family Medicine and director of the JFK Adult Autism Clinic within Children's Hospital. Dr. Kaylin Russell is a postdoctoral psychology fellow at JFK Partners and with us, and has been with us the last couple of years. She recently earned her PhD from the University of California at Santa Barbara in clinical psych. And she works with autistic individuals across the lifespan, working with assessment, support services, and in research. She's interested in supporting autistic individuals and their families and to receive better care and access. And finally, Ellen Wilkinson is a clinical psychology doctoral candidate. She's a clinical psych intern with us this year who specializes in working with autistic adults who have intellectual disability or who are minimally speaking. She's completing her PhD, is super close to completing her PhD at Rutgers University and her clinical internship with us at the end of June. So without any further ado, I'm going to turn it over to them. And thanks all for joining.
Thank you for that introduction, Judy, and thanks everyone for being here. I'm going to get us started with our presentation today on autism assessment in adulthood, talking about best practices and neurodiversity affirming approaches. So us presenters wanted to start by just sharing our values with you all. We honor autistic perspectives. We strive to provide neurodiversity affirming care in our work, in our practice, and we respect communication differences, which we want to demonstrate today. So feel free to communicate via chat throughout the presentation, and our presenters who aren't speaking will take care to kind of respond to those thoughts and comments. And then we'll have time at the end for Q&A where you all can unmute if you'd like. And then too, in all of our work, we really try to center autistic voices in a person-focused approach. Before we get started today, we want to hear a little bit about you all in the chat so we can make sure as we go, we're tailoring our presentation to best fit your needs. So we kind of want to hear from you, like, what is your role? How do you currently support autistic adults? And what do you hope to learn today? So we can take some time in the chat to hear about this. So we have a speech language pathologist in a hospital setting, another SLP in the public schools, an RBT in the public schools, school psychologist, professor of psychology and a practicing clinical psychologist, parent educator, other psychologists. This is super helpful. Thank you all. pediatrician, crisis response, fed director, school psych. Awesome. This is all super helpful for us to hear, and feel free to continue to say in the chat kind of who you are or what you might be interested in learning today. So thanks for sharing. I'll cover our agenda next before we really dive in. But we're going to start our presentation kind of setting the frame for neurodiversity and general diversity considerations. Then we'll go over just a brief overview of autism before moving on to talking about differing presentations and co-occurring conditions in adulthood specifically, and then talking about best practices and tools for assessment of autism in adults before we end with Q&As and reflections. So jumping right into setting the frame about neurodiversity. So some of you may or may not be familiar with the term neurodiversity or the neurodiversity paradigm, but it really is a movement to kind of shift how we're thinking about autism and just brain differences in general. And it really captures how, just like human biodiversity, we all have different brain wirings and brain differences. And so we're moving away from this sort of medical model and more toward being using the neurodiversity paradigm. And so I like to give a little caveat with this just because each person who is autistic and each family also might have different terminology that they identify with. And so, although here we have a list of kind of like outdated versus current terminology, I do want to acknowledge that everyone has different preferences. And whenever I'm working with individuals or their families, I always just like to ask them what they prefer and what they identify with. And if they don't know, I'll let them know, here's the terms I'm going to use. Today, just kind of based on, the current research and the populations that I work with, say they might prefer this language. But you let me know what you think. And if it grows and evolves, be open to having those conversations about what terminology and identities best resonate and describe you. And so when we're moving away from this medical model and more toward this neurodiversity paradigm, we're moving away from the core assumption that there is a normal way of being. Like I said, we're moving toward brains come in many different varieties. No two brains are alike. There is no normal. There's no better or worse. It's just a difference that we need to support to help people thrive. And so instead of thinking about autism like it is some sort of disease or disorder or that it's undesirable, instead, we're thinking about it as human biodiversity. And for a lot of people, it can be a part of their inherent identity. Um, Disability, we think of autism and disability as resulting from a poor fit between a person and their environment. So, more of a mismatch. Some of you may have heard of like the double empathy theory, right? So, thinking that mismatch is not because the autistic person has a deficit or is doing something wrong, but that maybe if they're communicating with a non autistic person, their brain wiring is different. There's a mismatch in how they're communicating with one another. And we think about that same thing when we're thinking about the environment as well. So the goal is to not change the autistic person, not to make them look less autistic. With this model and this paradigm, the goal becomes to help the autistic person be their authentic self and to provide them with tools and support services to help them live their best life, to improve their well-being. And this is really important to think about as we're going through the assessment process and asking the autistic adult or their family members, what's important to you? What supports do you need to live your meaningful life and to reach your goals? And how can we help you get there? Instead of just thinking about trying to make your autistic traits less visible to others. Other diversity considerations that are really important to know when we're thinking about autism assessment and how to support autistic adults is that autism is present in all racial, ethnic, and socioeconomic groups. However, a lot of people who are from underserved groups can have different barriers to receiving autism supports or even an autism diagnosis. And this could be due to different insurance issues. It could be due to geographical barriers. So getting access to a medical diagnosis can be really hard. Um, it can also relate to different awareness and understanding of autism of medical providers and what that might look like in people with different identities or in underserved populations. And so they might not be getting the best support from their medical providers in order to be linked to supports. And then there might be different stigmas or understanding around labels, whether it's mental health or neurodevelopmental, like autism. And so, as a provider, it's really helpful to think about this person or their family's culture and what they know about autism, and helping to maybe understand where they're coming from to either reduce stigma or provide more education to help connect people to the supports that they need. Another barrier is just that research has been primarily conducted with white, cisgender, born male people, right? So when we first started learning about autism, we're thinking about what that looks like in a young white boy with big behaviors. And we know that autism and the autism spectrum can vary in presentations. And because of this, a lot of women and females are unfortunately diagnosed 6 years later than their male counterparts. We also know that a lot of autistic people have trans and non-binary identities too, which is really important to consider in the assessment process because we're thinking about everyone's lived experiences and everyone's intersecting identities, right? So someone's identity, whether it's being autistic or it's a different identity, they don't exist separate in a vacuum. It all comes together. So we really want to make sure we get a full picture of what's going on for someone so that in every piece of them, so that we can help support them in the best way. Now I'm going to pass it over to Audrey, who's going to talk a little bit more about autism in general and different factors for referral.
Hi, everyone. I'm really happy to be here. When we look at the referrals for our clinic here at JFK, there are so many different reasons why people are invested and interested in undergoing an adult evaluation for autism. We divided them into two kind of categories here, but the reality is there are also system level factors as well. Lots of folks will share with me personal stories of struggle across the life. And messaging sometimes to people has been if you only worked harder, if you tried harder, you wouldn't have all these difficulties. And that kind of messaging can truly take a toll on a person over the course of their life. In undergoing an evaluation for autism, where explanations can be provided for social differences can be truly meaningful. It can really help this concept of self and be protective as well. Other factors that lead to folks seeking an evaluation may be misdiagnosis. We see lots of people who have undergone diagnostic evaluations in the past and have been provided diagnoses that don't truly feel like a good fit. So recently, I had an adult share a personality disorder diagnosis that she did not feel was appropriately taking into her account the full constellation of differences that she experienced, and honestly felt quite stigmatizing. Mental health symptoms can also drive evaluations, feelings of depression, mood instability, isolation, anxiety. All of these can get in the way, as Kaylin mentioned before, of people feeling like they're fulfilled and are able to live a life full of quality and authenticity. So, this concept of lifelong challenges and mitigating these challenges by working hard, burnout can be the byproduct. And burnout can also drive an evaluation. Lots of adults also have come in due to family stressors, either the toll of masking or recent diagnoses of autism in family members where they have really felt like that child's diagnosis has resonated with them. Going through that diagnostic process is a journey in and of itself, and reflecting on a child's behavior, similarities potentially between yourself and your child, and being able to take the lead and model that neurodiversity is part of one's family and one's identity can be very powerful. Some of the external factors I want to highlight here can be positive. Media awareness can be an incredibly positive and affirming factor that can lead to a referral as well. I have seen in recent years just increased access to voices of people with autism, many of whom are thriving and can shed light on the value of that diagnostic process. Not needing to necessarily know somebody personally with autism, but be able to understand that lived experience through social media can really drive an evaluation too. There can be negative factors that lead to an evaluation. We're often seeing people during very difficult and challenging times of life, whether it be loss of employment or need for workplace accommodations in light of challenging factors at the workplace. Many individuals are really thinking carefully now about how to balance their own sensory differences and needs with workplace environments that may not be accommodating to these differences. So really trying to think carefully about how can I maintain employment, gain employment, and be able to be authentic to my sensory experience as well. Other people who are really coming in, seeking out evaluations in part to confirm what they may know already, which is differences tied to their social and sensory needs, but really wanting to have documentation of that, whether it be for medical purposes, for mental health supports and services tied to autism, SSI, health insurance, access to waivers, and also for some people, access to supported decision making. So we have parents of young adults coming in often quite overwhelmed by the fact that their young adult has now reached the age of 18 and decisions need to be made, not only from a financial perspective, but a medical perspective. And navigating that without shared decision making can quite honestly be quite difficult. So thinking about ways in which to support young adults in adulthood, respecting their voice while also being protective of areas of need as well. And the last two I want to mention, medical recommendations often drive referrals, whether it's from a mental health toll on physical well-being or whether there are co-occurring medical conditions, feeding issues, sleep issues, and later in life, other symptom sets that might be aligned with an autism diagnosis. The last point I put here are legal issues. And I share this because unfortunately, legal involvement can be a byproduct of poor workplace conditions. So we see many folks who have had challenges at the workplace, have not received accommodations that they have needed, and there have been consequences for that, either loss of employment or even down the road, loss of housing. So legal involvement can take place for sure. And for some people, it could be custody decisions, or it could also be legal involvement due to misunderstandings, behavioral challenges, or social difficulties as well. Recently, I was working with a young adult who shared that his sensory environment was infringed upon. He had a physical reaction, pushed somebody away, police were involved, and then there were legal consequences because of that. So we can see how autistic traits that are not well supported can lead to behavioral difficulties that unfortunately sometimes are picked up through legal means as well. And we want to be supportive and advocates and do a careful job in our evaluations to meet the needs of these various referral issues. Next slide. Who do autistic adults turn to? Many adults are turning to primary care providers, psychiatrists, and mental health therapists. And it could be in part due to unmet physical or mental health needs. It could be that they are not currently diagnosed with autism and need support navigating the system. And oftentimes it's for the purpose of medication management. So it is really critical for us to be thinking carefully about how do we support adults to receive services that are most helpful to them. We know based on research that autistic adults are less likely to go to their primary care physicians for preventative care, many times in part because this is due to dissatisfaction with the healthcare system. It can be dissatisfaction with communication. It can be brief appointments. It can be feeling misunderstood. And these misunderstandings often will result in adults more likely to go to the emergency department than to receive preventative care. And so a big part of the evaluation process in receiving a diagnosis can be thinking carefully about how do I best navigate my needs so that I have relationships with providers who understand my complex constellation of behaviors and healthcare needs, and so that I don't have to result in emergency visits that may be better met by preventative care. So we want to be mindful of that too. Who else do autistic adults turn to? Social media a lot. Lots of folks report that they are able to very easily and successfully navigate resources online, and that is helpful in the sense that they don't feel as stressed through in-person communication, but there are limits to the knowledge and the expertise that one's able to find. We want to share some facts with you all. Most of you are probably very well versed with these facts, but we also want to acknowledge limitations in what we know about current numbers, prevalence rates, because most of the research on prevalence rates have actually been done with youth. So when we look at current numbers from the CDC, current numbers are 1 in 31 children nationally in the US receive a diagnosis of autism by the age of 8. 1 in 31 children does not translate to adults. So what we know is many of these children obviously will maintain these diagnoses across their lifespan. But what we know too is that lots of adults may have autism, but may not have a diagnosis. So we want to be mindful of the fact that we are assuming that there are high rates of autism in adulthood, yet we want to recognize that many adults do not carry that diagnosis. They may either be self-identifying as autistic or may not be aware yet or may experience barriers to that. We also want to highlight that autism is a neurodevelopmental diagnosis. This is really critical when we're thinking about evaluation in adulthood. We're not expecting behaviors and traits of autism to emerge in adulthood. We're expecting that these traits are present across one's life, but the impact of these traits may be more pronounced as people age. So we really want to do a careful history and really understand to what extent traits of autism might be impactful across one's lifespan. Kayla mentioned this already, but current numbers indicate higher rates of autism in males than females. So right here we have 3.4 males to every 1 female. There are lots of reasons why that may be the case. Kaylin described one reason already, which may be the presentation and characteristics of autism may look different in males than females. So females may be underdiagnosed. There could be genetic explanations for this as well. But we do want to be mindful that much of the research that we know and read about today is in part due to work that we have seen in males with autism, with research on females, and adults being more recent and being more emerging. We'll talk a little, I'll see in the chat resources related to ARFID, bulimia, anorexia. Feeding issues are very common in adults, well, actually in all people with autism. And we're happy to share some resources with people later about that too. But we want to highlight the physical and medical impacts of autism can go beyond feeding issues, sleep issues. Ellen will talk about that in just a little bit. We also want to acknowledge that there are a range of cognitive and independent living skills. We tend to think carefully about assessment of both adaptive, which is daily living skills, and cognitive, in part for qualification purposes for resources, in part for accommodations, and in part to see how traits of autism may be compensated for by people. So sometimes masking may result in impacts on one's processing speed, one's memory. So we want to be sensitive to the fact that there could be impacts, even though core cognitive abilities may be strong. We want to be aware that there can still be impacts across the board. And then the final fifth point, Ellen will talk about in a little bit more detail, but we recognize that there is a high level of co-occurrence between autism, ADHD, anxiety, and depression. And we think about this co-occurrence not only as a byproduct of being a brain-based condition, but we think about the co-occurrence as part of lived experience of autism, being in environments that may not be affirming, being in challenging situations where accommodations and supports may not be available. So there can be a toll that living with autism takes if these traits are not supported well. Let's move on to the next slide. The DSM really defines specific behaviors that are characteristic of autism across two domains. The first domain is social communication. When we're thinking about social communication behaviors in an adult, we're thinking oftentimes of a very nuanced view of what this may look like relative to a young child. We're tracking these behaviors over time, and we're really trying to inquire either from the individual or caregivers or partners or other connected family members a history of these challenges. Because while an individual may be able to report, it can be more challenging to reflect back on time and think carefully about what the impact of these traits may have been early in life. What this might look like might be challenges in interpersonal relationships. It might mean feeling misunderstood over time. I've had lots of people say that they were characterized as being mean or being unfriendly, in part because their face may not display the intensity of their emotional experience. And that may be harder for some people to communicate. I've had adults share that their passions are easy to talk about. Strong emotions are easy to be able to kind of share. But when there's that in between, that gray area, or topics that may not be of high interest, chit chat and small talk may be really, really difficult. And how that may manifest at the workplace may be very difficult as well. The nonverbal communication component is often one of the earliest reflection points for adults with autism. Many adults will share with me that they have historically always been challenged by eye contact. Looking at people in the eye may actually be painful, may be uncomfortable. And they may have received longstanding feedback that that may not be okay, not to look at people. So there can be consequences of difficulty with eye contact based on social relationships as well. What we're looking for is the integration of spoken language and nonverbal communication methods, whether it be through facial expression, linked eye contact, and linked communication from a verbal component. Pulling it all together is what we're really thinking about as an area of indication that autism may be at play if there are challenges integrating all three. And then perspective taking, reading social cues can be difficult as well. This final piece on developing and maintaining relationships is really critical because lots of folks will share that they may have interests, but may not necessarily have the skills needed to navigate complex social relationships or may burn out of relationships. So the sustaining of the relationship may be really, really difficult. So we don't want to take just like an all or none approach to relationships, but really dig in to hear from the individual what these relationships may be like over time. And the expectation is not numbers of friendship, but rather quality of relationships and how traits may be impactful on one's goals to sustain relationships. The next area that we're thinking about is the RRBs, which is restricted repetitive behaviors. So for many people, there can be interest that can be very, very pronounced in consuming and be passion points and can be fabulous. But sometimes these interests can become all consuming and can get in the way. So I've had lots of folks share that they get very into their passions, which is great. And then suddenly 8 hours goes by and they realize, man, I thought I was going to be at the computer for 10 minutes and it's now in the middle of the night. So sometimes these interests can take over. Sometimes these interests are fabulous career points, points of connection, can be fulfilling. And sometimes they can be very challenging because being able to move away from these interests can be marked by distress. Flexibility and issues of change can be really tricky as well. So substitute teachers during childhood, field trips can be very hard. In adulthood, it could be work trips. It can be a change in meeting schedule. I had an adult recently who shared that one of his formal accommodations that he wanted at work was no surprise meetings after 3 o'clock in the afternoon, because that kind of threw off his departure time, that threw off his commute, and that was very impactful. So thinking carefully about how this may come into play in different aspects of your life and how accommodations could be supportive. The last component here is sensory differences. We all have different sensory needs, but there are times when our sensory needs may be a mismatch with the environment. And that's when we're really thinking about here in the diagnostic process. Are there sensory differences that can be impactful? There can be sensory interests and preferences, but there can also be aversions that can be intrusive and can get in the way. Even within the context of our clinic, I worry about the noise level in the clinic. I worry about the lights. The fluorescent lights can be very uncomfortable, and thinking carefully about ways in which individuals are able to kind of navigate their day-to-day life. Next slide.
All right. So when we're thinking about different presentations of autism, I'm going to start with talking about considerations for women specifically, because as we've already noted earlier, women get diagnosed later in life, and this can have to do with the fact that their presentation looks different from how providers in the past have typically thought about autism. And so Audrey had some really wonderful examples that are demonstrated on this slide when we're thinking differently about our diagnostic criteria for autism and how it might look in women. So, like she mentioned, we're not just looking at can they initiate relationships, but what do the friendships look like, and can they be maintained over time? Are they only kind of structured within a work environment or within a college environment? And then in those unstructured times where you might be meeting outside, it's more difficult. Um, a lot of autistic women too can appear socially successful from an outsider's perspective, but then getting that inside look, noticing that there's intense social burnout. I've worked with women who have gotten a first-time diagnosis in their 40s, 50s. The oldest I've diagnosed was a woman in her 70s for a first-time diagnosis. And one of them was a very successful exec in the TV world. And she would say that she would go to these movie premieres, she'd go to these like Academy Award shows, and she'd be able to do it, but she would leave, go home, and she'd have to call in sick for the rest of the work week because she was so socially burnt out from having to really perform at that event. That she was unable to work the rest of the week and needed a lot of time to recover just in her room to recharge her social battery and take care of herself. We also hear a lot of women using social scripts. In order to appear like neuronormatively successful in social interactions. And so they might practice ahead of time or kind of borrow from TV shows or movies or books and create some scripts to help them engage in reciprocal conversations. This can be exhausting, like I mentioned, to try and keep up socially. Imagine these aspects don't come naturally to you, and you have to work really hard actively in your daily life in order to get by and appear successful and get opportunities that other people have because of this mismatch between your social style, how your brain works, and what society expects of you. And so, like Audrey said, a lot of these women feel really misunderstood. Um, when we're thinking about the RRB piece too in women, a lot of times their interests that are really specific or intense, they might socially fit in. And so if you're thinking about kind of the like old school interests for autism, things that come to mind are often like trains, right? Some autistic women are interested in trains, but sometimes their interests might feel like they socially fit in. So, for example, I've worked with a lot of young women who love Taylor Swift. Taylor Swift is a hot topic right now. So many people love Taylor Swift. And so, on the surface, you might not think, well, that doesn't sound like it could be an RRB from an autism standpoint. Um, and so we're not just looking at what the interest is, but we're looking at the intensity of the interest and if it can get in the way. So I've worked with women who will always have an earbud in playing Taylor Swift at all times. And if the earbud dies or they can't have it in, it's super distressing. Or maybe they stay up really, really late watching videos of Taylor Swift, like doing some research on her, reading Reddit pages about her songs, and they forget to do their college homework or they stay up too late and then miss their alarm the next morning. So, not just thinking about what the interest is, but how it might impact them. We're also thinking about diagnostic overshadowing and fewer externalizing behaviors. So, the 70-year-old woman that I diagnosed, her whole life was just told that she was quirky or introverted and a little anxious. And so, people just kind of wrote her off as being introverted and socially anxious, when really she had unsupported, unrecognized autism. And after receiving that diagnosis, totally saw herself through a different lens, was able to support her anxiety in a different way and understand herself in a different way and advocate for herself in a different way. And so she noted having to like think back on her past experiences and kind of grieve that she never got the support that she really needed and deserved because people weren't seeing her or understanding her for who she was and for what was really going on for her. And a lot of times these things are misunderstood or missed because of masking and camouflaging. And so when we're assessing for autism, we really want to think about masking and camouflaging as part of someone's presentation. And so autistic masking or camouflaging is defined as like acting in a manner to pass as non-autistic. This often feels like performing and can require a lot of effort and mental energy. Now, autistic adults have noted that masking isn't always bad. And there was actually new research about this by an autistic researcher at the recent International Autism Society conference that just happened last month, where he was saying, sometimes masking can be helpful. Like if I'm going into a job interview and I know that I need to do small talk and I know I need to look toward the person interviewing me because this job is so important to me, masking can help me in that situation. But then there's other times when masking can be extremely unhelpful and can contribute to mental health challenges because maybe I'm with my friends or my family and I feel like I have to mask in certain ways, and then I'm masking 24/7 and I don't get the chance to be myself, and it feels exhausting. So when we're assessing for autism, we're not just seeing, okay, what traits do we see on the surface when I'm interacting with them? We want to think about what's going on internally for them. And we'll talk later about different types of interview styles or surveys and assessments where we can really get at this internal experience. Masking is more common in females, but that doesn't mean all people don't mask. It can happen to any degree in multiple um, different presentations. Um, and and yeah, so just really thinking about this because new research showed that concerns about camouflaging can cause family, friends, and also like examiners and diagnosticians to not recognize their autistic traits. So if you are assessing a young adult or even a teenager or an older adult who's coming in, they might be thinking, I wonder if they'll see the true me or if they'll understand me because I know I mask or I know I might not be able to show my true presentation. And so just allowing them to unmask or asking them about their internal experiences can be really helpful in the assessment process. The last thing I want to speak to now about different presentations before I pass it on to Ellen is just acknowledging the spectrum. So, autism is a spectrum in that no two people are alike. Traditionally, how the spectrum has been viewed in the medical model is thinking about low functioning versus high functioning, or a lot of autism versus a little autism. And we find this to be extremely unhelpful because every single person has their own unique strengths and their own challenges across a range of domains. Every person is so multifaceted and deep and has all these different areas of their life. It doesn't feel right to put them on a straight line and say you're either here or here. And so if you Google autism wheel, that is what I like to do. And I'll show it during feedback sessions after giving an autism diagnosis and saying, instead of thinking, how autistic am I? Or am I low functioning or high functioning? Think about yourself in these different domains across your personality and who you are, and that can help us think about where you need areas of support or where you have amazing strengths, and we can really lean on those to help you meet your goals and be successful. So that autism wheel can be a really helpful tool in feedback and in therapy if you do therapy with individuals who are exploring their autistic identity and what it might mean for them.
Hello. Thank you, Caitlin. I'm going to take over and talk a little bit about autistic traits in people with intellectual disability, as well as autistic adults who are minimally speaking, because this is a little bit of a different presentation that if you are diagnosing autism, thinking about what autism looks like in adulthood across the spectrum, we do see different things. And so it's important to have a little bit of an understanding of kind of what this can look like in all different kinds of presentations. So when thinking about autism in those with intellectual disability, it's important to remember that their traits may look different depending on their developmental level, also called their mental age, rather than simply their chronological age. So, in other words, behaviors should be interpreted in the context of where the individual is developmentally, while still, of course, respecting their chronological age. So, for example, if someone has a developmental age or a mental age of 4, but they are 30, you would not expect them to have the same autism symptoms, the same behaviors as someone who has a a typical sort of developmental age, a typical mental age. So when you're kind of thinking through autism symptoms, you need to be accounting for that developmental piece as well as chronological age. For many individuals with intellectual disability, we see more noticeable delays in those early forms of social reciprocity. This can include things like not consistently showing or pointing things out to others. You might see less imitation of gestures or actions. You might see reduced social smiling. And something we very commonly see is differences in social inhibition. So I think of the people who I do diagnostic assessments with who may come in and not notice their shirt is rolling up, or they may not have a sense for different bodily functions in the room, things like that. These challenges may appear more pronounced in this population because those really foundational social communication skills are just developing at a different rate, developing more slowly. They may come online at some point throughout their life, but it does tend to be delayed. Um, Restricted and repetitive behaviors also may look somewhat different. Interests in this population are often centered around sensory experiences, routines, familiar objects, rather than those highly specialized kinds of topics and passions that Audrey mentioned. So, for example, a person might have a strong preference for certain textures, certain repetitive movements, or even like really consistent daily routines. I'll talk a little bit about this more in a moment, but it's also really important when you're doing diagnostic evaluations and considering autism in those with intellectual disability to know that they are much more likely to experience co-occurring medical conditions, especially things like sensory and motor challenges, which further affects things like communication, behavior, daily functioning. So the medical piece, while you don't need to be an expert in diagnosing medical conditions, you should know what is often co-occurring in this population so you can keep an eye out for it and make referrals as necessary. At the same time, if you go back, yeah, just real quick, strengths from my experience are often overlooked in this population in working with these families, writing reports, asking questions. It's really important to have time to capture someone's strengths. I have found that many of these individuals show really strong social motivation. They have really meaningful relationships with familiar caregivers. They really thrive with visual kind of learning schedules. They have really excellent memory. And recognizing these strengths is important because they can guide intervention approaches. They can support quality of life, support independence, support what this person and the family are going for. And just big picture, as Kaylin has talked about, we want to have an individualized approach where we really appreciate who someone is, what they're bringing to the table, big picture. Okay, now you can go to the next slide. Thank you. So I would be remiss if I didn't stop and point out that outside of intellectual disability in autism, there's also a group of people who are minimally speaking. So the numbers for this do range a little bit. For intellectual disability, it's somewhere between 30 to 40% of autistic people have intellectual disability. For those who are minimally speaking, it's somewhere between 20 to 30%, and these groups do not perfectly overlap. So of autistic people who are minimally speaking, these are people who don't use verbal speech to communicate consistently. There are people within this group who don't have intellectual disability, like I said, and they may even have nonverbal cognitive skills in a typical range. Where what we're seeing is the autism in particular is impacting those communication abilities. And I use the term minimally speaking. Specifically, the other words have been used like nonverbal, minimally verbal, but this is really reflecting that this group of people, it's not to say that they can't communicate, it's that they don't use spoken language to communicate kind of their needs, their wants, and communicate their experiences. So there are some data. I just have really, really quick sorts of things just to show you that if you're working with this population, you interact with someone who is minimally speaking, we do have somewhat of an understanding of what autism looks like in this population, and there really is ongoing research for this. So what you see here is a study that was published a few years ago by Vanessa Ball and her team looking at socio-emotional reciprocity, nonverbal communication, and maintenance of relationships over time. So you see T1 to T19, which is these individuals were 2 years old to 19 years old. And we see whether you're verbal, you have delayed speech, or you're minimally speaking, your symptoms do change over time. And on average, these autism symptoms kind of decrease in impairment over time. It's not just the verbal individuals that we see development, that we see things changing over time. If you'll go to the next one, I'll give a really, really specific example if you're thinking through, okay, but what do I do with this information? This is some unpublished work that comes from the same group looking at really specific autism symptoms. So response to joint attention, you see is the two columns all the way on the left. You can see 98% at age 2 of the minimally speaking group were showing impairments in response to joint attention. And then by 19 years, that number dropped down to 19%. So there was a great development of joint attention over time. So we can't purely go off one's kind of mental age or developmental age, because clearly chronological age is important in this group. There's something happening with development where joint attention is coming online. They're using joint attention much more. We see the same for gestures in the middle there. The number drops from 93 to 59%. But we don't see a change in symptoms over time into adulthood with range of facial expressions. So some things you can't rely on those kind of classic younger child kinds of autism symptoms like joint attention to look for autism in someone who is minimally speaking. So let's take a second. I'm going to ask for some engagement from you guys. We're going to talk through a few case examples that these are real cases, real people that we've seen as a team in the last few years. And I'm going to start with 2. We pulled some kind of differing kinds of presentations. So what I'm going to do is I'm going to read this case example out loud. And as you have thoughts, I want you to put in the chat what you would be thinking about in terms of information you'd be wanting, questions you'd want to ask, and big picture, what we're looking for is for that case conceptualization, appreciating this person as a whole, getting their whole picture, as well as diagnosing autism specifically. What would you be wanting to know or ask if you were doing this evaluation? So as you have thoughts, feel free to just put them in the chat. So Alyssa is a bright 35-year-old woman who lives with her husband and 2 children. She works part-time at a nonprofit. She was diagnosed with ADHD while she was in college, but wonders if there may be something more going on for her. She is seeking an evaluation to determine if she has autism. She also has a history of heart racing, intense worry, and self-blame. Alyssa reported that she often has difficulty understanding sarcasm, making close friends, and perspective taking. She has a strong sense of justice, relies on using scripts in social situations, and has difficulty when expectations are not clear. Alyssa avoids certain public spaces due to fluorescent lighting. She and her husband are interested in understanding how to support her mental health, her relationships, and overall well-being. So I'm going to pause for a second. Think about what you would want to know about Alyssa, or if there are any components of this that really stand out to you that you'd want to dig deeper into. See, Emily is wondering about history of developmental delays. Totally. I would wonder if Alyssa has someone who can report on that, whether it's like a parent, a grandparent, a sibling who's much older, family history of autism, other psychiatric conditions, hobbies, what does she like to do? Love that. Yeah, what the strong sense of justice looks like, and if that impacts her kind of day-to-day life in any way. Self-awareness, see if she's validating self for this, minimize shame, totally. Yeah, you're calling out some really specific things that are important to think through. Let's see, a few more coming through. Onset, totally. Developmental history, why she works part-time. Yeah, that's a really important detail. Could reveal additional avenues for workplace accommodations, understanding of sensory and social needs, peer relationships, medications. Are they helping? Sensory difficulties. I love the calling out the working part-time. Not that everyone has to work full-time at all, but I wonder if that's something that she would want and kind of what is getting in the way of that. So I think about adaptive behavior as well. I think about anxiety with the history of heart racing, intense worry, looking for any regression, asking about relationships, sensory needs. Why now? I love that question. That's something we often, or pretty much always, with our um, adult cases start with, okay, why now? What brings you here now? That gives a lot of context for kind of the goals of the evaluation, what they might be looking to get out of it. I love it. Thank you, everyone. Those were all super, super helpful thoughts. Let's talk about this next one that is very different, but I'm curious if we'll have similar thoughts about what information we'd be looking for. So Kate is a 26-year-old woman who is minimally speaking and has a rare genetic disorder associated with intellectual disability and macrocephaly. She lives at home with her parents and has attended a day program since finishing school at 21. She uses some single words and single signs at home to communicate her needs. Excuse me. She was referred for an autism evaluation because her parents wonder what kinds of supports are best for her long term. Notably, she goes through month-long phases where she exhibits compulsive behaviors related to routines and touching objects. In direct assessment, she completed activities to assess her general development, adaptive behavior, mental health, and autism symptoms. She did not speak during the evaluation, other than signing more several times. She sought out sensory input from lights and physical touch. She looked at the examiner often and used few facial expressions like happy and afraid. Sorry for the typo there. She used a few facial expressions like happy and afraid. So for Kate, what would you be thinking? What would you want to know more about? Social interest, relationships, totally. Access to other forms of communication like an AAC. Yep. Strong sensory preferences. The AAC is a really is one that definitely came up and was talked a lot about in this evaluation. Yep, communicative function and intent, because parents reported more communication at home than in the evaluation. So kind of what's causing that discrepancy and how can she be better supported to communicate? Totally. Yeah, what about previous supports? Have they not been helpful when Kate is having compulsive behaviors? Has she always had these kinds of behaviors? You're calling out the kind of medical and mental health co-occurring condition that we're potentially seeing here with the compulsive behaviors? Is there something else going on? Do we need to make referrals to neurology? Do we need to be looking for OCD? History of communication supports. Yep, and medical conditions, totally. So Kate is an example of someone who may need more time to be thinking through and talking through those co-occurring mental health and medical conditions, and may need more referrals to kind of figure out the best way to be supporting her. Thank you, everyone. So let's talk about that. Those co-occurring, we're going to start with mental health diagnoses. So I have listed here the kind of the most common mental health conditions that can co-occur with autism. So we have ADHD, anxiety, depression, bipolar, substance use, obsessive compulsive disorder, post-traumatic stress disorder, and eating disorders, which has come up in the chat. It's really important to remember that autism does not prevent someone from having these mental health conditions. And in fact, autistic individuals are increased risk for many of these due to factors like chronic stress, social difficulties, sensory overwhelm, bullying, trauma, difficulties with emotion regulation. And at the same time, the really diagnostic understanding of each of these is extremely important because autistic traits can look similar to some of these mental health disorders. I've seen many individuals who come in with a diagnosis of bipolar disorder or with an eating disorder or OCD. And through the diagnostic evaluation, we find that autism does fit them, and sometimes those other disorders do not, and sometimes they do still kind of meet criteria. So one specific example is like repetitive behaviors may resemble OCD. Social withdrawal may appear similar to depression. Emotional dysregulation can look like bipolar disorder. But this is where I encourage you to really understand the root of the presentation. You want to be asking not just what the behavior, the externalizing part is, but also why it is happening. So it's for people who can report on their internal experiences, you want to spend a lot of time getting to know the why behind. Let's go to the next slide. And I'll just touch quickly on diagnostic overshadowing because Kaylin has already mentioned this. But this we see very, very often with autistic adults. This occurs when behaviors are attributed entirely to autism while another mental health condition might be present, or the other way around. So the example I have here is comparing autism and social anxiety, which do have overlap that you can see in the middle there. Both can involve discomfort in social situations, social withdrawal, preference for being alone, difficulty maintaining friendships. So the presentation can look very similar, but the underlying reasons are different. In social anxiety, the core issue is typically a fear of negative evaluation, embarrassment, maybe. Individuals may want social interaction but avoid it because of anxiety. In autism, the difficulties are more related to differences in social communication, in social processing. So this can be things like difficulty interpreting facial expressions or body language, sensory sensitivities, or becoming overwhelmed in social environments. And both of these things can still be true at once. Someone can be autistic and have social anxiety at once, but that is not always the case, even if the presentation looks similar. So you want to be understanding the why behind the behaviors. And then to touch on the medical diagnoses as well. So you'll notice I talked about mental health, and this is more medical diagnoses. I have Parkinson's there first because this is something that if you're working with adults, autistic adults specifically, you need to be aware of. Parkinson's occurs much more frequently in autistic adults, and the onset can be sooner. So it's something you need to be looking for and making referrals as needed. We also see obesity, seizures and epilepsy, intellectual disability, sleep disturbances, sight and hearing impairment, gastrointestinal syndromes, and Ehlers-Danlos syndrome. All of these things are very commonly co-occurring with autism.
So now we're going to set the stage for the evaluation. We really try and focus on the individual goals. What would you most want from this evaluation? What are you hoping to achieve? And what are you hoping to receive additional supports with? Um, Explaining the evaluation process is really core to any evaluation, but this is particularly true for adults who are undergoing an autism evaluation because it's a little bit different than many evaluations. It's unusual in some ways to request to speak to a parent of a 40-year-old. That may feel a little uncomfortable if there are fractured family relationships, or it may feel like the voice of the individual is being discounted. So it's really critical to explain what we're looking for, why we're looking for specific traits and behaviors, and really highlight the goal and the shared understanding of this process. Consent obviously is required to reach out to any caregiver, any family member, and we really defer to the individual as to who is best able to kind of report on that early history. And sometimes that's not possible, and that's okay too. We love to hear about what the individual's understanding of autism is. I would say the majority of people who are coming in for evaluations have completed countless questionnaires online. Lots of people come in with a stack of papers. I got a 128 on the CAT-Q. I did the RITVO. My score was in the autism range. And so incorporating that information, they're coming to us with a wealth of information, not only from their own experience, but their research and understanding what a diagnosis could mean and what it also might mean if we don't provide a diagnosis. There can be a great deal of distress associated with not receiving a diagnosis of autism if they have identified with autism for quite some time. So just being on the same page about the meaning and the value behind the evaluation, and then using a strength-based approach. We really try and be as responsive to the individual's goals and needs as possible. Next slide. So a recent study came out in 2022 that looked at community clinicians in the UK, and it indicated that 69% used autism standardized assessment instruments when evaluating adults. We don't have studies in the US right now that indicate the rate by which people are using standardized assessment procedures. In Australia, another recent study came out and said about 50% of clinicians were using standardized assessment procedures, such as incorporating the ADIR, incorporating the ADOS, incorporating measures that were created for the identification of autistic traits. So what this means is, as a field, there's a lot more work to be done to be thinking about measures that are best equipped to kind of tap into these traits, and also recognizing that not all practices are incorporating standardized approaches. When it comes time to thinking about other mental health, adaptive, cognitive, behavioral needs, we want to be using best practice assessment measures too. Even if people are not expressing concern about their cognitive abilities, IQ testing can be incredibly helpful to be able to highlight areas of strength, spike skills, areas of need, and to be thinking carefully through accommodation, how masking may have impacted behaviors over time, and what burnout may do to processing speed. We also obviously want to do a comprehensive mental health evaluation and identify areas where compensatory approaches have been very helpful in one's life and areas of difficulty as well. Next slide. We are just one person in this individual's life. of seeking understanding. And so we want to acknowledge limitations of the moment, and incorporate history from other people of value. Many times, family members may not be able to provide a history, and there are other sources of information that could be super valuable. Former evaluations, former IEPs. If an individual didn't receive support through school, there could be other kind of ways to access areas of need or difficulty. And then moving on, we are always thinking about next steps. We're one step in the life of an individual, and we will be thinking carefully about who are the other people who will continue to be able to support this person moving ahead. Maybe it's job coaches, maybe it's vocational support, maybe it's from the medical partnerships that we need to carve out through primary care psychiatry. So recognizing that the evaluation is one step of a person's journey, and being mindful that facilitating next steps can be very overwhelming. So really trying to think carefully about prioritizing who the individual should see post-evaluation, how they can set that up, and what really is critical in their own life for next step support, so that we can really kind of facilitate that process. There are lots of challenges tied to the evaluation process. Kaylin mentioned the importance of creating an environment where unmasking is safe. We really try and encourage people, show us your true self. Be comfortable to share that. If you're not, be able to share that in other means. Maybe that's through written reports about what masking looks like. Maybe it's through journaling of experiences that they have had. So really relying on the individual to be able to share a history, so that as a clinician, we're not trying to bark up the wrong tree. We also want to know that medication can impact presentation. So we don't want to downplay impact of symptoms that may be effectively medicated, or be suppressed in part because of medication. And I think the other components here we've discussed already. From the individual standpoint, next slide, we want to acknowledge that navigating a medical evaluation is incredibly challenging for lots of reasons. And many people come to us feeling misunderstood, invalidated, and also carrying a lifetime of burdens that may not be acknowledged immediately by most providers. So we want to be able to recognize how challenging the process of an evaluation is. Lots of people will tell me that post-evaluation, they need 2 days off. So thinking carefully about, this is a difficult process. Have you thought about how you will manage kind of the end of the day tonight, tomorrow, as you reflect on the day, as you experience exhaustion from working so hard on the evaluation process? What supports can be put in place? And then financial and insurance issues obviously are system-based issues that can be incredibly challenging. Next slide. Almost done.
Okay. Last but not least, we want to talk about the feedback process. So, as clinicians, it is our ethical duty to provide informed feedback to our patients or our clients in whatever setting you may be seeing them in after providing an assessment. To me, the feedback is the most meaningful and important part of the whole assessment, because this person has been so open and vulnerable with you throughout the whole process. They've been brave in coming in and exploring and learning more about themselves. And now it's your turn. It's your job to make sure that they have been seen and heard and validated. And so it's so important to be really thoughtful about how you approach the feedback to wrap up the evaluation. I can't tell you how many times I've had people coming in for a second opinion or a reevaluation talking about how the first assessment was unhelpful or harmful because of the approach to the feedback and then also to the report writing. And so when it comes to feedback and report writing, we want to make sure that we are continuing to incorporate this neuroaffirming framework throughout the feedback and the way we write the report, and that we are also using the individual's priorities that they talked about in the intake to help guide our framework for the feedback and for the written report as well. So like Ellen said, that question of what brings you in, what supports are you seeking? We want to take that and frame and build our feedback and frame and build our written report around their priorities. A lot of times when we offer the information that they may or may not have gotten an autism diagnosis, we always want to pause and see how it's landing with them. What's going through their mind? What are their initial questions before we go into all the details or their initial thoughts? And a lot of times with adults, it takes a lot of time to support their responses of maybe frustration. Why didn't I hear about this earlier? I am 50 years old and I've gone my whole life without knowing, and people have treated me wrong because of my lived experience. So supporting their frustration, or even if this is their second evaluation and someone told them they didn't have autism before, also supporting the validation they might feel. I did a feedback this morning where the person said, "Oh, this is so validating. I can trust my gut about myself. I don't have to have imposter syndrome about identifying with being part of the autistic community," and really validating, yeah, you did the right thing. You came in here. You know yourself well. You were right. And I'm sorry that no one supported you in getting here earlier. Some people might feel relief too, right? I've heard people say, "Oh, good, nothing's wrong with me. I'm just autistic." I'm like, exactly, that's exactly right. Nothing's wrong with you. You're autistic. Um, just all different things that might come up for people, taking time to support them and process them in that moment. Also, using objective language in non-judgmental manner to describe autism too. Doing this from the very beginning, setting the tone, understanding autism from that strengths-based approach. Like I said, throughout the entire process, from the intake through the time you send out the written report, this can help validate and affirm the person and or their family. Um, it can also be really helpful to do some teach back. So I want to hear your main takeaways from everything we shared today, just to make sure that their main takeaways are the same as what you were saying, making sure that they're not kind of misunderstanding you. We would hate for them to take away, something's wrong with my brain. I'll never be able to achieve my goals. That is not what we're saying today. So if that's a main takeaway, we want to take time to address that and correct it. Or we want to see what their main takeaway was from what we provided and what was really salient to them. Maybe they did understand and take away the same things we were saying, but what was salient to them? And then also just acknowledge that receiving full reports can be so overwhelming. Some of our reports can be tons and tons of pages long. And so ending feedback with really clear next steps and takeaways so that they don't feel super overwhelmed when you just send them the report. Acknowledging my door is still open. Come back with questions. Come back to read through things with me so that they don't feel alone or paralyzed when they get to that point. Last, we'll just take a quick, like 3 minutes to go through this case example so that we can leave the last 10 minutes open for questions. But as I read through this case example, I want you to think of, now that we've covered assessment tools and feedback, think about Carlos and what types of tools you might consider using to help support him in his evaluation. So Carlos is an 18-year-old Mexican American who is accompanied by his mother for an autism evaluation. He was identified with a language disorder in elementary school and had an IEP throughout his education. School-based testing indicated that his IQ falls around 70. Carlos experiences significant sensitivity to loud noises in crowded environments. He also has difficulty with back and forth conversations and a lack of close friendships. He has difficulty navigating his leisure time and completing household chores. Although he wants to work after graduation, he has struggled to find a job because during interviews, he has difficulty answering interview questions and expressing his desire for the job. He and his mother are seeking support as he transitions into adulthood and graduates high school. So, in the chat, real quick, if you all could type, what types of assessment tools would you consider using when working with Carlos to help him and his mom figure out supports as he graduates and wants to find a job. Yeah, so I see you're talking about the Vineland 3, so a type of adaptive behavior. Yeah, you could use a Vineland or you could use an ABAS to get at that adaptive behavior. You could have him potentially do a self-report or have his mother fill out or do both. Get a functional language sample. So yeah, looking at his well, one, his language abilities, like receptive and expressively, but also how he uses his language communicatively, because we know that social communication skills can look different than someone's expressive or receptive language abilities. Do autism assessment and clinical interview developmental history to get at if he's meeting criteria for autism. You can do an ADOS for that. That's right. IQ test. That's right. Yeah, we did end up doing a Stanford Binet with him just to help meet his needs in a test that might be more accessible for him. Adaptive measures, clinical interviewing, and executive functioning, all great ideas. We also did some mental health surveys too to see if anxiety is getting in the way for him, especially socially during these times of interview too. So really great, well-rounded responses. Thanks, everyone. All right, and now we can use the last 10 minutes for questions. But before I stop screen sharing, I just wanted to share our thank you slide and our references. But we can move on to questions and feel free to either unmute if you would like, or you can pose your questions in the chat. We're happy to have you all reach out either way.
I have a question.
Yeah, go ahead.
So during the MIGDOS training that I attended, I was sitting next to a school psychologist who said, I'm just going to stay with the SRS. I know it. It gives me good information. We always do a child study. So we all bring our various assessment data in. What do you think about that?
Personally, I found that the SRS is not one size fits all, and it's not, for me, the best way to collect information or to learn about a person. I would prefer to use a more interactive assessment, even in addition to the SRS, if you do want to get a survey report as well. But different presentations can look so different, and I think the SRS doesn't capture all presentations, and it doesn't do a great job of qualitatively capturing strengths as well that you can get from a more interactive assessment like an ADOS. I'm not sure, Audrey and Ellen, if you have more to add.
No, I have the same thoughts. We also know the SRS is overly sensitive for people with intellectual disability, or kind of differing cognitive functioning. And it's a survey, right? It's very different from the MIGDAS. It's not an interview. So to me, you could get both, but you can't compare them, use them similarly.
Thank you.
Some of the items on the SRS are perceived to be a little bit offensive. So I think we're in the position right now where the language we use really matters. And some of our instruments contain questions in language that can be off-putting for people as well. And so acknowledging that that is true of many of the instruments, inclusive of the SRS as well. But I agree, we would never want one instrument to be diagnostic. You're really looking for a full compilation of assessments, self-report if that's possible for the individual. and observation and a history.
I noticed too a question in the chat about assessment tools that are generally recommended at baseline. This is really hard to answer just because different tools are going to be appropriate for different folks. We generally do that developmental interview, cognitive assessment, and like autism specific assessment, and then mental health assessment as well. And so depending on the person, whether it's their age, their language abilities, or the different maybe mental health symptoms that are coming up for them, what we're going to use. I will say with adults, like one general tool that I think never hurts to use it, unless it's above their language level, would be the CAT-Q. It's the camouflaging autism questionnaire. And when I have worked with folks where that survey might be a little difficult to fill out for them, maybe due to their reading level or what may it be, I will just kind of turn it into an interview and ask them some of those questions in an interview. But different cognitive assessments might be more or less appropriate based on where someone's at, whether it is like a WACE or a Stanford Binet or a LIDER. And same thing with like a Vineland versus an ABAS. Audrey and Ellen, feel free to chime in.
Yeah, the beauty about the Stanford Binet is it cuts across the ages and can be used for people with intellectual disability or people who have less developed language. So I do like the Stanford Binet. The challenge is the norms are a little bit older. So we tend to use a WACE if it's possible. If it's not possible, the Stanford Binet. If the individual is minimally speaking, the LIDER is a great nonverbal assessment. Some people will use other kind of standardized assessments too. I do see a question about autistic burnout in college students. We are seeing that a lot too. We really do recommend thinking carefully about course load from a pragmatic standpoint, meeting with the counseling department or the Office of Support Services. Each college calls it a different name, but all colleges have a support clinic or Office of Disability Services that can be incredibly helpful. So step one is really thinking about what resources can be leveraged in the institution, thinking carefully about course load. Lots of people go in and take a full course load, and that may not be recommended. Thinking carefully about the balance. Sometimes it's hard to balance work and classwork, so really trying to reduce that. Thinking carefully about how the individual best communicates and needs help. Maybe that's accommodations for email support as opposed to office hours. And also mental health support, I guess, would be number one as well. Let's see. Other questions? Evaluations for SSI. Gosh, I have really struggled with this because some people we have provided a diagnosis with have not qualified for SSI. So we really try to encourage people to know their rights, know that if their SSI request is denied, that then they should be able to request either a protest and a re-eval, but we would agree. We have provided comprehensive evaluations that document the diagnosis, and sometimes it's still denied. So I think it's very challenging. At that point, it's asking, thinking carefully about, responses to the denial as well. Any other thoughts about that, Kaylin or Ellen? And I think we're just about out of time. There was one other request earlier about supports tied to feeding, ARFID. We really do recommend occupational therapists a lot for adults with autism who may have selective eating, who may have sensory needs and differences that can really incredibly impact their feeding. So really trying to leverage support from nutrition, from occupational therapy, and then there are some specific feeding disorder clinics in town that do have expertise in ARFID, it's really difficult though to find places that have all of the expertise, adults, autism, and ARFID. And our occupational therapy colleagues, I think, are very well positioned to be good advocates for adults with autism. I think we have to end. And I am so appreciative and so grateful of the time. We acknowledge that it's a short amount of time to cover a complex topic, and there may be huge areas that we have missed. Please feel free to follow up with any of us individually. We'd be happy to fill in some of the holes that we may have missed. We also appreciate your time and attention. So thank you so much. The handout will be on the website. Dina pasted a link in there where you can look out for the handout. Okay, thanks so much, everyone.